Good morning, everyone. Welcome to Cardiac Sciences Grand Rounds for March 26th. This morning, it is my great pleasure to introduce someone known to many of us, Dr. Nishant Sharma. Dr. Sharma is one of our job candidates for the interventional and structural heart position here at the University of Calgary. Dr. Sharma comes from Saskatchewan, where he did the majority of his training, medical school and residency. Has come to Calgary, worked for a year, I believe, with which cardiologist? With Vida for a year, and then chose that he wanted to keep doing training and punish himself a little bit more, so went on to do an interventional cardiology fellowship. He spent this year doing some advanced training in mitral clip and TAVI procedures, and today is going to give grand rounds on mitral transcatheter edge-to-edge repair. Okay, Nish, welcome.
Okay, thanks, Dr. Howard. So today I'm really excited to present a topic that has garnered a lot of attention over the last few months here in Calgary. So just to start off, outlining the burden of disease, we know that MR is very prevalent, with 10% of patients over the age of 75 having significant MR. When left untreated, the consequences of severe MR include significant changes to LV dysfunction, reduced cardiac output, and pulmonary congestion. And all of this leads to heart failure, hospitalizations, and increased mortality. Briefly, we'll just go over quickly the different categories of MR, and this is important in terms of therapies delivered. So as we know, primary MR, also called degenerative or organic, relates to actual anatomical issues with the leaflets or subvalvular apparatus. Leaflet degeneration can really mean prolapse or flail leaflets. And that's typically Carpentier type 2. And that's the most prevalent in Western countries. When you look at Carpentier 3A, it's more frequent in lower income countries. Secondary MR, which is kind of type 1 and 3B, really relates to annular changes. So there's not a lot of anatomical issues with the leaflets, but you have annular changes that cause difficulties with coaptation and resulting in an MR. You can have subvariants, including issues with leaflet motion and restriction, which can be seen in ischemic and non-ischemic causes. And then there is kind of a subgroup of secondary MR, which is atrial functional MR, where, whereas traditionally secondary MR is caused by increased tethering forces and a coaptation line that is beneath the annular plane. In atrial functional MR, it's more of a central jet that's caused by flattening and dilatation of the annulus with the coaptation line at the annular plane. We see a lot of this in patients with HFpEF and atrial fibrillation. So when we evaluate these patients and they get to the point where it becomes severe or symptomatic, they kind of go through an algorithm of treatment options. And that's kind of categorized based on etiology. So for primary MR, really they go through a surgical risk triage where if they get a better result with surgery, they kind of go down that route. But if they don't, or they're prohibitive for surgery or high risk, then this option of transcatheter devices could be considered. Secondary MR, which probably has a lot of more of the traditional evidence behind it, goes through more of an anatomical streamline. So if patients fit a coapt-like anatomy, which is the trial name, then they would kind of go down the transcatheter route, and non-coapt-like would kind of go through various other options. And that's kind of been the traditional approach. But what I'll outline today is that there's been some variations in that. So when we look at the landscape of transcatheter devices, it's pretty broad, and this picture could actually be a bit more extensive, but this is just for highlighting a point that there are different options available targeting different parts of the anatomy. For the purposes of this talk, we're really focusing on leaflet targets. So that would be the mitral clip, which is an Abbott product. And then I'll highlight some info about Pascal, which is an Edwards product that isn't approved yet in Canada, but is approved in the States and Europe. So obviously, this is not a journal club. We're not going to go through every trial. What I will highlight is that there's been over 20 years of good data, at least earlier on. The trials really prove the efficacy and safety of mitral clip devices. And more recently with registry data, we really have good evidence for hard outcomes such as mortality and heart failure admissions. So the leaflet target really was kind of introduced by Dr. Alfieri in 91. And his idea was to create a double orifice by suturing together the A2 and P2 segments of the mitral valve, essentially creating this double orifice and reducing resultant regurgitation. He showed that there was very durable surgical results long-term, and that even extended out to patients that didn't even get an annuloplasty. So this video, it's playing, just kind of a brief overview of the device. It is a transvenous access with a 22 French sheath. Once we get to the right atrium, the first step is kind of getting a good transeptal puncture to get access to the left atrium. And I'll highlight later on why this is super important. That gives us our height above the valve, essentially. Once we get an adequate position, we introduce the guide into the left atrium. The newer devices have the ability to monitor left atrial pressure throughout the whole procedure, which is really helpful. And then you introduce your clip, which angulates down towards the mitral valve annulus. And a lot of your manipulations happen or should happen in the atria before you kind of angle below the valve apparatus. Here you can see the clip arms are open. And then as you advance into the left ventricle, you kind of adjust your clip orientation and trajectory accordingly, being sure that you're not buried in deep trabeculae or entrapped. And then once you got a good result, you drop those grippers, you close the arm, and you kind of can check on flow. There's times to kind of go back and readjust if you want, so it's not fully deployed yet. Once you're happy with your result, you eventually release the clip, and then you can reassess your resultant or residual MR. At this point, you can decide to add a second clip, or you can stop the case. But you know, this is an animation. They don't all go that smoothly. So essentially, you know, what are we trying to do with edge-to-edge repair? How do you emulate a surgical result with a transcatheter device? The original paper from Alfieri had a lot of annuloplasty designed into the procedure. And so the early thought was that this would be a criticism of mitral clip because we're not really getting that effect, that annuloplasty effect. But what we've come to realize over kind of long-term CT data is that there is in fact a reduction in the AP diameter of the annulus. And so you are getting a pseudo annuloplasty effect, which is really important to note. The actual alloy that the mitral clip uses is an alloy alloy, which is a combination of different metals. So this is important because it has a magnitude that's stronger in terms of its material and adherence compared to other devices and other metals. It has a very low profile, really shown to have good tissue-to-tissue coaptation, which can actually interrupt and reverse annular dilatation and remodeling. This is important to understand that full leaflet insertion is important. So on the left, you can see that, you know, once you have your grasping tissue, there's actually no loss of tissue insertion during closure, which is an important aspect of the design. There's distributed forces along the mitral clip, but if you actually look down to the detail, you get the most force really at the crux. So if you look at this image on the left, ideally you'd want your tissue right down to the crux because that's where you're going to get your most adherence force. Additionally, the grippers or the frictional elements have these angulated elements that are kind of going towards the mitral clip. And so originally there was some issues with, leaflet tearing on the first generation of MitraClip, but they've come a long way to improve that it's more of a grasp rather than a tear. So there's just some design elements that you should be aware of. Pascal and Pascal Ace, which is the Edwards product, works on the same basic theory. Additionally, it has a central spacer, which is designed to fill the coaptation gap and minimize regurgitation. It has two paddles designed to minimize stress concentration on the valve leaflet. And it has this elongation feature, which is nice. It helps kind of reposition and navigate throughout dense chordae and can reduce the risk of entanglement once you're in the left ventricle. It does have the ability to independently grasp, and it has a single row of these elements, whereas MitraClip is kind of the full spectrum. So we'll talk a little bit about which cases may be beneficial for this device. So when we look at M-TEER, like I mentioned before, a lot of the original evidence comes from secondary MR. We won't go through all the trial details, but just as a quick update, COAPT was kind of the landmark trial for MitraClip in secondary MR, and they came out with their 2-year results and most recently their 5-year results. And what they've shown is that, at least in the 2-year results, which are displayed here, really good hard outcomes for hospitalization mortality with a number needed to treat of 3. This was kind of the first time in CLIP history that they showed a mortality benefit. And a lot of that benefit extended out to the 5-year follow-up group, where there was still a maintained benefit. There was a lot of crossover between groups, which was allowed after 2 years. A lot of that was from the control into the device arm. So that's why you see some plateauing of the curves. Just quickly on mitral FR, which is published at the same time as COAPT, completely different results almost. And so there, at least at the time in 2018, when both trials were released, there was some controversy as to what exactly were the differences. So they didn't actually show a difference between the interventional group and control group. But when you look at the subgroup analysis and the patient demographics, they work a little bit different. So there was more severe MR with smaller LVs. The COAPT patients were a lot more aggressively medically optimized, very highly selective patients. So there was actually a 61% exclusion rate with COAPT. COAPT had a lot more operator experience. So there may be a selection bias in terms of centers involved. And then there was more residual MR, which we've come to know is a pretty big impact on outcomes. So a lot more with mitral FR compared to COAPT. There was also this theory that maybe there's disproportionate MR. So essentially the LV did not dilate enough in COAPT patients to accommodate the degree of MR. And perhaps that's an ideal time to target M-TEER. And then when they get too dilated, like they were in mitral FR, perhaps the benefit is less pronounced. So just is this hypothesis generating hasn't really been proven yet. So overall, for secondary MR, we try to look at them based on the COAPT criteria. And so if they fit into the category or the group that they study, that's kind of where we go in terms of offering them the therapy. But the question is, that's RCT trial data. How does that apply to real world? So the COAPT post-approval study was really interesting. It actually looked at a prospective observational study looking at patients treated with CLIP across various centers from 2019 to 2020. And then they kind of categorized them into COAPT-like or mitral FR-like patients. And what they found was that the real world data actually matched the trial data pretty consistently in terms of for COAPT. So for heart failure, hospitalization, mortality, pretty on par with the trial. For mitral FR, they actually found lower combined endpoints for all-cause mortality in the real world. And a lot of that was driven by lower heart failure hospitalizations. There's extended kind of evidence for patients that don't meet the COAPT criteria, and I'll kind of touch on that at the end. A lot of movement in the kind of the advanced heart failure setting, so patients with very bad LV function, where there's actually really good outcome data. In transplantation, they've actually found that in certain sub-cohorts of patients, they've been actually relisted and removed from the transplant list. And then atrial secondary MR, which is kind of a new term that we've all been kind of using a lot in the mitral valve space. We're really understanding the pathology behind it, and there's more data to come about which patients would benefit most from M-TEER. So in primary MR, it's a little bit of a different animal altogether. As we know, primary MR is fairly undertreated for all comers. And the decision not to operate really coincides with comorbidity index. In addition, we know that this has impacts on mortality. Data has consistently shown over the last few decades that if you can get a good repair, that's preferable over mitral valve surgery. And that's been a consistent finding over the last several decades. When it comes to M-TEER and primary MR, really good data. This graph on the left is kind of a registry data for all comers, so not center-based. So all patients that were kind of reviewed in the European data using third-generation systems. They had a pretty good 30-day outcome of 89% success rate, although they were defining success as less than 2+ MR, which is a bit generous. Expand G4, which is using a more up-to-date current technology, had even better results at extending up to 1 year. But they had a little bit of a selection bias in terms of center experience. So that kind of plays into the role of some of them. But nonetheless, there is really high success rate in this cohort. The Expand G4 registry also looked at patients with complex anatomy, which represented about 140 patients of their group, where 80% of them had primary MR. And this complex anatomy, which would usually be prohibitive for M-TEER, they actually went and attempted it and had pretty good results at 1 year, achieving a residual MR of less than 1 in 90% of patients. What I think is more interesting is that registry data, which is more of all comers rather than a site-specific registry. They defined pure MR or primary MR as abnormal leaflet or chordal issues as a result of prolapse or flail. Similarly, they found that there was really good outcomes for these centers over 1 year mortality and heart failure. What we do know is that less MR is better. So even though that registry said success is less than 2+, which is moderate MR, we know that the less MR you have residually, the better you do. And that's kind of the take-home message from that, is that, traditionally the outcomes were getting to 2+ MR residually, but now the target should be getting to mild to trace. Pascal, like I mentioned before, really has maybe an avenue to get into this market really with primary MR. So their landmark trial was the CLASP trial, which is a non-inferiority trial, which showed no real difference between Pascal and mitral clip. Interestingly enough, the clip patients were using the current generation G4 in majority of the cases, and Pascal was using their older generation in majority. So even despite Pascal using an older generation technology, they still had very good comparable results. There was a subgroup analysis of patients in that trial that actually did not get offered mitral clip. They were declined for anatomical reasons, and then underwent Pascal, and they had really good outcomes. So maybe a future avenue for them to get involved. So there are still a lot of gaps in primary MR, and there's not a lot of randomized trials. A lot of them are single center and registry reports. These 3 trials are kind of ongoing in terms of enrollment, and they'll really look at the comparison of surgical mitral valve repair versus mitral clip in low, intermediate, and high-risk patients. So that'll be a lot more telling in terms of where we go in terms of future therapies. Predictors of success overall, like I mentioned before, less MR is kind of what we're going for. Risk factors for recurrent MR, we know include large flail or prolapse gaps, residual MRs. So once your clip is deployed and you can check on transesophageal echo in the OR, we know that if you're leaving the OR with a little bit of MR, that a little bit of MR begets more MR later on. And oftentimes it's underestimated in the OR just based on the loading conditions and the sedation. So there are some centers that are considering doing a brief debitamine stress echo just to see what the heart does under different loading conditions to get a true estimate of what's residual. And then clefts, which, are overall kind of difficult to assess, whether it's echo dropout or a true cleft. But if there is a true cleft, that might be an anatomical consideration. The mechanisms of residual MR, when it relates to the device specifically, are kind of outlined on the right here. So you get single leaflet device attachment where the device is still attached to one leaflet and not to the other. Loss of leaflet insertion, where both are inserted, but they have migrated away from that crux area, like I was mentioning before. You can get actual mechanical damage to the leaflets with tearing or prolapse. And then there's functional etiology. So the clip is in fact intact, but you get continued annular dilatation, which causes increased tethering forces. So in that category, that we commonly say, MR is a disease of the atrial ventricle. And so managing those will help decrease this scenario happening long term. But overall, the incidence is low. Other things that we don't do this often, but is this thing called coaptation reserve. Basically, this coaptation reserve is the measurement of the distance of the opposition between A2 and P2 segment. So basically, you have a good grasping zone to put in a clip, you get a better result. If you don't, you get a less favorable result. And that's something that is shown to have good clinical outcomes. So kind of in summary, we're looking at these patients in terms of success risk. So, is the complexity there, free leaflets available for grasping, absence of clefts, and perforation risk. We also look at the cost of reducing MR comes at the cost of stenotic risk. So patients that have had prior rheumatic disease or radiation, severe MAC, or more smaller mitral valve areas. And then obviously other non-anatomical things like access and imaging quality. So jet complexity on the left, better, it's more central, A2, P2. As we get more to the right, multiple jets, more in the commissural areas where difficult to put devices, and that's in the 3D imaging. Leaflet complexity, ideally you want these long leaflets, mild tethering or a focal prolapse. And as you get to more severe tethering, shorter grasping zones or calcium, it becomes a bit more challenging. And then this is just an example of clefts. Like I mentioned before, important to know what a true cleft is versus echo dropout, and that's what we rely on our echo colleagues to help us discern. So overall, what do we know? Significant and durable MR reduction is possible. And now we're trying to target MR grades less than mild. We know that the benefit extends to both primary and secondary MR with really good clinical outcomes. That complex anatomy is not prohibitive. And so we're seeing a lot of benefit in patients that were traditionally declined clip based on certain anatomical features. And then expanded role for non-coap patients. So they did kind of a subgroup analysis in that expand registry looking at clip-like patients and non-clip-like patients, and really no difference in terms of outcomes. Heart failure hospitalizations continue to decrease, and so this is the most up-to-date trial data that we show that overall the one-year rate is about 17%, which is the lowest it's been recorded. And the all-cause mortality rate continues to drop. So overall 12.3%, which is the lowest it's been in a real-world registry. We know the procedure is safe, which is probably the biggest plus to this procedure, is that that you can get away with very little harm to the patient. And so this is kind of our general approach to our triaging here in Calgary. So we look at patients based on anatomy, and if they're more green, they're more non-complex, more like the coap patients. they'd be ideal for M-TEER. And as you progress to the right, to the more orange and red, you get into more anatomical complex cases. However, this is in context, so the experience matters essentially. So as you get more experience, you can take on more challenging cases, and that's where the benefit comes. So future direction of M-TEER, really a role in cardiogenic shock. There's a lot of case report data on the use of this technology in acute patients who are in shock, specifically ruptured papillary cords or muscles from late presenting infarcts, extending role to moderate risk patients, in transplantation patients, really looking at this atrial functional subgroup. And then the newer generation of mitral clip is coming. I think 2025 is kind of the next upgrade. And then will be interesting to see once Pascal gets approved. So it was good to have competing valve technologies to see which one works better for which anatomy. And there might be an avenue for them to be involved, especially with commissural jets, shorter leaflets, or dense chordae to help navigate that. So just briefly, I'll touch on our experience here in Calgary. So as you know, the program launched officially in November. After talking with Dr. Kent, the number that was provided was about 30 clips per year for up to 3 years. We've done 10 up to date, which is pretty mixed between primary and secondary MR, with pretty reasonable outcomes considering we have taken on more challenging cases for an early center. I'd say about just over half have mild to moderate residual, and a couple may need repeat clip, which is not uncommon. But overall, we're pretty happy with the result. It's 1 procedure day per month in the hybrid OR, and cases are reviewed and triaged twice a month. So once at the mitral valve clinic, and then once on the actual OR day in between cases, because that's when the whole group is together. Patients are kind of seen as an outpatient at the mitral valve clinic at South Health, which runs 1 Friday a month as well. And that's staffed by CV surgeons, interventional cardiology, imaging, and we will try to incorporate other ancillary healthcare services like heart failure. So I got this from the nurses over at South Health campus. This is just a quick snapshot of where to find this referral. So through Connect Care, you can find the internal referral form, and you kind of search the department for South Health campus, cardiac valve clinic, minimally invasive, and then you kind of put your comments or indications there. Of note, they need to have a TEE prior to the referral, just to make the clinic visit more worthwhile. So just a couple quick snaps of cases that we've done here. So this is a transeptal puncture. What we're aiming for is more of a superior to mid-fossa location and posterior. And the positioning really matters because as shown in that animated video, you have to end up angulating down to the mitral valve. And so you have to have adequate height to make that turn. So we spent a lot of time really landmarking where this is. I think I probably came into this at a time where it's a lot easier to do with radio frequency ablation. But Dr. Kuryachin and the EP service has been gracious enough to have me in with them to learn some of the old school ways of doing this. So I have an appreciation for how far this technology has come. And so you have your bicable view on the left, and then your short axis of the base, really showing you that you can angulate away from the aorta. This is just the guide coming across the septum. And then here you can see the clip and delivery system are kind of now into the left atrium, and the goal is now to angulate down. And now you're just checking your trajectory with the clip arms are open here. Now you're below the valve apparatus, and the goal is obviously to have the anterior and posterior leaflet onto the actual clip arms, and then you can drop your grippers accordingly. A lot of the manipulation is done in the atria before you get down to the ventricle, just because you don't want to be entrapped in all the trabeculae. We always check 3D for orientation to make sure that we're exactly where we want to be anatomically and in relationship to where the pathology is. Here's an example of yeah, so there the leaflets are on the grippers here, and you can see that they've dropped accordingly. Then we check in both the short axis and the commissural view to make sure that we're properly aligned. And you can see here on the right that, you can see the grippers bouncing, so you have a good indication of your leaflet insertion. The newer technology of clip that's coming out will actually have sensors on here to indicate how much leaflet has been inserted. So that's going to be a nice new feature. And then here you can see the clip arms are closed and the clip is deployed with really good minimal residual MR. Those are just a couple pictures from the group. On the left is kind of our first implant day in the morning of, just kind of meeting with OR and the cath lab staff just to go over cases. On the right is most of the clip team. I believe Chris P was in the OR getting the patient ready, but it really is kind of a collaborative program with lots of moving parts. So I want to just thank Kelly and Dr. Howard for the opportunity to present today. The cath lab staff and OR staff who do a lot of the background work and the grunt work to make everything that we do in the hospital really run smoothly. Obviously, Dr. Curtis, Kent, Adams, and Tripkov for really offering their expertise and really getting this program off the ground and running. Heart failure service, which is something we want to incorporate long-term into the clinic, and more recently have been really helpful in helping admit these patients, especially the secondary MRs, and getting them titrated on appropriate meds. Deb and Stacy at South Health, Nicole Cook from Abbott, who has been really supportive of our endeavors. And then Dr. Eckstein, who's from Saskatoon, who is a colleague of mine and a friend who graciously just let me join her. And she taught me a lot to do with the clip procedure itself. So yeah, that's all I have.
Thanks, everyone. So we will open up the floor to questions, both online, in the chat, and in the room. So any questions in the room off the bat? I have one. So as far as designing patient selection, you talked about the co-op trial. This is very important. In the Calgary context, how do you see the referral pathway running? What do you want the kind of general cardiologist referring into the clinic? How do you see the clinic and the imaging operating in order to choose?
That's a great question. It's really a combination of outpatient and inpatient. I think the outpatient pathway is pretty streamlined. So patients that are referred to that clinic aren't necessarily offered clip. They're being considered for clip. So it's kind of a clinical evaluation. The decision isn't made by one person. It's kind of by committee. And so I find that process really works well. We have kind of early growing pains, as any early program would. So really patient selection for this procedure is key. And I think we've learned through a couple of cases of which patients we should be attempting versus not, which has really changed our paradigm. But overall, it's been really good for the outpatient. For inpatient clip services, it's been a little bit trickier because we don't really have a formalized program yet. I think most of the referrals go to Dr. Kent and Dr. Adams, who then kind of communicate to the group. Because at the end of the day, I think they see mitral valve therapy more from a comprehensive perspective. So not only medical therapy, but different transcatheter devices, surgery, clip being one of their tools. So that's probably more appropriate for them to be involved to look at it from that perspective. But we haven't really formalized the inpatient process, which is kind of the next step.
Nish, great talk. Thanks for the presentation. My question is related to surgical patients. So if you have a patient that has previous surgical mitral failed, are these patients prohibited from getting TEER in the future? And if not, what's been the experience in TEER patients who have had previous surgical repair?
Okay, well, that's a great question. So Daniel, cardiac surgery resident, asked just for the people online about the experience with M-TEER in failed mitral valve repair patients. So I think it just depends on the repair. We have done one here with a failed neocord, which hadn't been done anywhere before. So we had got a lot of expert opinions from other centers about how to attempt that. And we had a pretty good result, surprisingly. So I think the biggest issue is, you know, how does the device interfere with a previous repair? Sometimes the anatomy changes completely after that mitral valve clip is placed. So we have limited experience. There's not a lot of data out there though. And some of that new data that's coming out that I mentioned may highlight some of that gap in knowledge.
One question.
Yeah, go ahead.
Nice presentation, addition, great images. Some of those complications you showed where you get a single leaflet or kind of boost, is that all intra-procedure or is it usually down the line? It's hard to predict upfront.
So Dr. Kuryachin asked about some of those device-related complications. Are they things that we can see in the OR? Are they things that we see in follow-up? The one that we've had was in follow-up. And I think most of them are at that 30-day mark because the safety profile doesn't change from 30 days up to 1 year. That's what the data suggests. So that really highlights that if you're going to have an issue, it's going to be in that first month. And after that, really, we don't see a lot of changes. That's what the data would suggest, at least. Yeah.
So Nish, first off, congratulations on getting MitraClip off the ground here in Alberta, because it's been a province-wide goal for at least 10 years. So the fact it's finally come to fruition is, and also for, you know, bringing together other team that you have on there, plus EP, countless others to get things. So, you know, now that there's a program going, at least in Southern Alberta, and, you know, assuming Edmonton gets going. So if you think about just Southern Alberta, what do you envision like the volume to be like in the kind of medium to long term as, you know, as you and your kind of annual volume for Southern?
So Dr. Har was asking about anticipated volumes in the future. I think it's going to be really big. The difficulty we have is limited resources with 30 clips a year. When I talked to Dr. Kent about this, I think there is motivation to expand the program eventually, but we're still kind of getting our feet wet per se. So I think time will tell where we go in terms of what we can offer. I do think the referral base is going to get really big, especially as soon as we get heart failure into the mix. I was at the implanters meeting a couple months ago, and heart failure is now adding this as a pillar of their therapy. So, you know, it helps them titrate medications appropriately because all the afterload changes. So I think it's a moving target, but I do anticipate a lot more referrals. It's just a matter of meeting that demand.
Ask anyone online in the chat or just to speak up online. I'll just give you a minute to do that. Okay, if not, thank you very much. Sharma here.